Hello everyone. And conservative surgery has largely replaced the amputation. So, is the surgery only is responsible, or is there any role of RT as well that we are going to see? So, wide local excision and radiation therapy is standard of care for patients with high risk soft tissue sarcoma. When we say high risk, then automatically low risk are safer. Like we hardly need radiation therapy in low risk group. So RT offers absolute local control benefit of 20 to 30% based on different studies. Then these are all parts of patient workup that we have discussed already. So the layout of the presentation is when we should give RT, when we should not, pre-op versus post-op, timing, how much the dose, margin and volume, which modality, complications, and then brachytherapy. So brachytherapy we will discuss in next class along with some latest articles on RT as well. When is the role of RT? Surgery alone can be treatment for T1 lesions less than or equal 5 centimeters, low grade and superficial tumors, widely excised with acceptable margins. And what is that acceptable margin? That is 1 centimeter or more than 1. And less if their intervening facial barrier is present. As we all know, Kawaguchi principle applies in the limb salvage surgeries. So fascia also gives the margin of resection, it adds in that. So surgical plane should traverse normal tissue outside the reactive tumor zone. All high grade, large and marginally excised low grade sarcomas benefit with adjuvant RT. Then data in support of surgery for low grade sarcoma only. So there is this Baldini et al. Article of 1999. It was a retrospective study from Dana Farber, and 74 patients were studied of trunk and extremity. Median tumor size was 4 centimeter. 50% were low grade, treated with surgery alone. 10-year local control rate was as high as 93%. So in low grade, there is no role of RT. Then how things evolved. Prior the treatment standard of care was amputation. Then there were studies comparing the amputation versus wide local excision, that is limb salvage surgery plus RT. So this was a study done by Rosenberg et al. And amputation versus wide local excision plus post-op RT were two standard arms there. Local recurrence rate 15% was 15% in the wide local excision plus RT group, while it was 0% in amputation arm, though the overall survival was similar. So from there, things evolved and the limb salvage surgery became a norm over the years. So post-op RT level 1 evidence, RCTO post-op RT versus surgery alone. And the margin should be 1 to 2 centimeters. As we can see, 10-year local recurrence rate in high-grade sarcoma, patients receiving RT plus chemo, there is 0% local recurrence. While in no post-op RT only chemo, there was 22% local recurrence. It is statistically significant. In low-grade sarcoma also, we can see it is significantly statistically significant if the margin is less, especially. So in high grade, it is a norm we have to give. In low grade, depends on the margin. That was a study by Yang et al. So post-operative evaluation of quality of life done. Patients treated with RT had increased edema, worse range of joint motion, decreased limb strength, no significant difference in the global quality of life. So median follow-up of almost 18 years, none of the patients treated with RT developed local recurrence, and patients receiving RT had better overall survival as well. Then level 1 evidence of RCT, comparing RCT as brachytherapy with observation after surgery only. So we can see in high grade group, local recurrence after surgery is 30%, after surgery with RT is 9% only, which is statistically significant. While in low grade group, it is, though there is some difference is there, almost 10% difference is there, but it is not statistically significant. Then systematic review of adjuvant RT, and this is a important reference for us all. Systematic review was done, including 5 RCTs, 6 prospective studies, and 25 retrospective studies, almost 4,500 patients. So adjuvant RT improves local control in the soft tissue sarcoma of extremity and trunk with negative or marginal or minimally microscopic positive gut margins. Local control rate was as high as 90% with adjuvant RT. It was published in Acta Oncologica in 2003. So till now we have to conclude that, like in high grade sarcoma, we should give radiation therapy. In low grade, it depends upon the margin. Then impact of adjuvant RT on overall survival. So from the studies we have discussed, we can say that yes, local control rate definitely is benefited, especially in in both, but in high risk high grade sarcoma, it was statistically significant in every study. So does it impact the overall survival as well? So as we can see, this is a SEER database of around 7,000 patients and extremity sarcoma treated with limb sparing surgery with or without radiation therapy. As we can see, 3-year overall survival in low grades, there is no difference between RT or no RT. In high grade, there is difference and it is statistically significant. In large tumors, in large more than 5 centimeters tumor of high grade, there is difference and it is statistically significant. So RT also improve the overall survival as well. When post-op RT, when we should give features that put patients at higher risk of local recurrence after surgical resection, like tumors more than 5 centimeters, be it low grade or high grade, lesions deep or invading superficial fascia, high grade tumors, narrow, high grade tumors of whatever size, like even if it is less than 5 centimeter, narrow or positive surgical margins, and local recurrence after prior surgery. Though in practice, we often see that it is not followed as such because of the difference in opinion and the local complication rates. So what are these things? Like we should give pre-op RT or post-op RT. As we can see, there is comparison and things are better in pre-op RT group, except there is increased wound complication rate of 35%, which is almost double of post-op RT group. So in pre-op RT, we have to give lower dose, smaller field size, reduced fibrosis and reduced edema is there. So why we have to give less dose in pre-op RT group? Because after the dissection, we have to cover everything like the incision, the drain site. So the field increases and we don't know exactly that up to what limit the tumor is. And this is added advantage in the pre-op RT group. We exactly know the three-dimension thing that this is the tumor and up to what we have to cover. So this is one study done by O'Sullivan, pre-op versus post-op RT, and the primary endpoint was wound complication at 120 days. Secondary endpoint was local control and overall survival. So as we can see, 7-year local control rate is equal in both arms, pre-op versus post-op RT. Acute wound complications, we can see 35% in pre-op RT, post-op RT is 17% only. So pre-op RT group having almost double acute complication, wound complication rate. And while on the contrary, the late grade 2-3 toxicity, be subcutaneous or of any other site, it was more in the post-op RT group. Is it similar for both upper limb or lower limb? So the answer is no. In upper limb, the wound complication rate is only 5.5% with pre-op RT, while in lower it is around 43%. So the decision also depends on the site of the sarcoma. And this is a systematic review and showing in almost every study the wound complication, acute wound complication rate is higher in the pre-op RT group. So how we can decrease it? Using the conformal RT, avoid primary closure with wound tension, free flaps from non-irradiated areas, use of drains for sufficient time, gentle handling of tissue during surgery, and identify patients whom post-op boost may be omitted. like negative margins, pathological complete response, low-grade tumors. So again, this is a study for pre-op versus post-op RT done by the National Oncology Database study. It is including 821 patients of extremity as well as non-extremity sarcoma, and comparison was made between the pre-op RT versus post-op RT. And 60% patients were having negative cut margins, 17% received chemo in this. So as we can see that the 5-year overall survival in pre-op RT group was 65%, and in post-op RT it is 60%, and the result is statistically significant. So pre-op RT improves the overall survival. Then 5-year cancer specific survival also better in the pre-op RT group. 5-year local failure free survival also better in pre-op RT group, and especially it is useful in the synovial sarcoma and leiomyosarcoma. So when we should give post-op RT, patients treated with post-op RT within or after 4 months of surgery were compared, and recurrence-free survival, as we can see, it is 83% versus 64%. So 4 months, still it is a big duration. We should ideally try to give it within 4 to 6 weeks. So indications of post-op RT, all high-grade tumors, large or marginally excised low-grade tumors, pre-op RT, better long-term functional outcomes, equivalent local control rate compared with post-op RT, increased post-op wound complication rates. Those, due to various reasons, still it is not widely practiced. Then the next questions arises, which modality? So options are perioperative brachytherapy, better we call it. Like brachytherapy, we are placing the catheters during surgery, but we are not giving RT at that time. So better we can call it perioperative brachytherapy. Then EBRT alone versus IMRT, or EBRT plus brachytherapy. So in brachytherapy, intraoperatively, 9-hole catheters are placed in the target area of operative tumor bed, spaced at 1 to 1.5 centimeters interval. 2 centimeters craniocaudal and 1 to 2 centimeters radial margin around the tumor. Treatment usually starts 4 to 5 days after surgery. We put the catheters during surgery, but the RT starts after 4 to 5 days. Then the brachytherapy gives the advantage of simultaneous boost we can give, because it is very close to the tumor bed. We can give simultaneous integrated boost. So localized radiation with maximum sparing of the surrounding normal tissues, and then this is the second advantage of it. We are giving high dose to the tumor bed. Second, we are sparing also the normal tissue around. So it is radiobiologically better, short and convenient. Small rate of wound complication is there. Wound complication is 2 to 14%. Chronic bone injury is 0 to 4.5%, and chronic nerve injury is 0 to 10%. So the risk of bone fracture or bone injury is around 4.5% to the max in the brachy group, while in the EBRT group it is up to the range of 7%, that we will see in the next forthcoming slides. Limitations of brachy are large target volume. Like say if the tumor is more than 10 centimeter, we have to cover a large area, then we cannot use brachytherapy. Restriction of catheter placement because of the 3-dimensional anatomy of the bone and visceral organs. Like say if it is close to the groin or in the head and neck, we can not use because of the anatomical constraints or proximity to the important organs, say genitals and all. So anatomic sites where good catheter geometry is difficult to achieve, like around shoulder. Then indications of brachyradiotherapy: high-grade lesions with favorable surgical findings, complete surgical excision with negative margins, regions that cannot be encompassed well with the brachytherapy catheters, and usually less than 10 centimeter pediatric sarcomas and previously irradiated patients. Then brachy can be used as boost as well. EBRT plus brachytherapy we can give. And indications are when target volumetries cannot be adequately covered with brachytherapy alone. So organ at risk restriction, atypical geometry, skin ulceration that we already discussed in the last slide. Patients with high risk of recurrence, that is more than 10 centimeter positive margin or recurrent disease, we should avoid the brachytherapy alone there. We can give EBRT with brachytherapy. Advantage of adding EBRT to brachytherapy: potential to safely dose escalate to a large clinical volume with the cumulative RT dose. So we can give boost as well in the form of brachytherapy, which will decrease the bone complications and the surrounding soft tissue involvement. So this is a study on brachytherapy boost done by Andrews et al. As we can see, 5-year local control rate in stage 3 group, EBRT brachytherapy group, it is 100%, while in EBRT alone, it is 62% only. And 5-year local control rate in high grade is 100% in EBRT with brachy, while EBRT alone is giving only 74%. So both are statistically significant. So we should give brachytherapy boost in the selective cases along with the EBRT. Brachytherapy boost, theoretical advantages are RT starts in immediate post-op period, controlling tumor repopulation. In the perioperative period, tissue tend to be less hypovascular or fibrosed, making RT more effective. So brachytherapy catheters are in contact with the tumor bed, giving higher RT dose to the potential areas of microscopic disease. Can safely treat soft tissue sarcoma but in the neurovascular structures. Then we discuss, we'll see some slides about the conventional external beam radiotherapy, usually with APP or bilateral fields with sparing of lymphatic corridor with excellent local control rate. So this, we have to leave some area of assuming or marking the pathway of lymphatic drainage to reduce the lymphedema. Complications are edema 10 to 20%, fibrosis, bone fracture 0.7 to 7%. So bone fracture risk is more with EBRT, not with brachytherapy. In brachytherapy, it was only 4.5%, and decreased range of motion can be there. So we have to pay attention to optimum positioning of the limb extremity. Examples like medial aspect of thigh, if we have to cover, then we have to do the hip abduction and knee flexion. Anterior aspect of leg, we have to raise the affected leg on the styrofoam seat, give bilateral field and spare posterior compartment and opposite leg, and retract genitalia from the RT field. So as we can see, the positioning is very difficult for the conventional EBRT. 3D RT or IMRT evolved. Advantage are ability to confirm the dose of desired target volume, sparing of the surrounding normal tissue, allows reduction in the sparing of circumferential margin at the soft tissue and bone interface. Then a study regarding the treatment efficacy or treatment outcomes of IMRT. 41% patients were studied. Adverse factors were size more than 10 centimeter, deep location, positive cut margins, and close margins. So all high risk patients were also included in that. And this was the radiation dose, 63 gray. So 5-year local control rate was 94% for patient with positive or negative margins. Hence, it provides excellent local control, and all the toxicities were of lower range compared to the conventional RT. So IMRT has the advantage of reducing the local complications while having the almost similar local control rate. Now IMRT versus brachy, as we can see, EBRT versus IMRT outstands. So can we give brachytherapy in every case? As we already know, no, we can't give because of the organ at risk and because of the 3D anatomy. Placing of catheters is difficult at some areas, so we cannot give in every case brachytherapy. Still, we will see some studies. Retrospective analysis of adjuvant RT with brachytherapy or IMRT. So higher local control rate with IMRT, as we can see, and despite the high risk patients included in the IMRT group. So which modality depends on the availability of expertise and facilities. Long-term results and experience of brachy are also good. Perioperative brachytherapy still remains preferred modality. along with the IMRT. So radiation field size, it should be, if the size of radiation field we keep less than 5 centimeters, the local control rate was 30% only. If we make more than 5 centimeters, then it was 93%. So this is in contradiction to the Brecky, where 2 centimeter margin is considered adequate. Still, we need prospective trials addressing margins. Rationale for margins: microscopic extension of tumor beyond gross disease. As we know, soft tissue sarcoma is a compartmental disease. It may have skip mets far than the tumor because of the neovascularization and all. So we should give more than 5 centimeters of coverage of RT ideally. Then in myxofibrosarcoma, we should also give wider field RT because it has higher probability of local recurrence. Then the CTV and all are not that important for us. So how much volume? We spare lymphatic corridor, avoid inclusion of entire joint space, avoid full dose RT to adjacent bone to reduce the risk of pathological fracture, include scar and drain site at least phase 1, and use wedges or tissue compensator, or use 3D or IMRT to minimize the dose heterogeneity. How much dose? Dose response relationship for post-op RT. Local control rate is inferior for patients receiving less than 60 gray. So total dose should be given in phased manners. In R0 60 gray, then R1 64 to 66, and R2 66 to 70. Then post-op RT 60 gray in 30 fractions for patients who fulfill all the criteria, that it is R0 resection, primary presentation, extremity or superficial trunk tumor, age less than 64 years, other than MFH or MPNST, epithelioid sarcoma. For patients with any unfavorable feature, we have to escalate the dose. And for positive or unknown margins, we have to give 68 gray. Then complications: radiation associated pathological fractures are rare but serious complications. Incidence is 1.2 to 6.5%. So it is more in the EBRD group. Factors indicating risk include age, gender, anatomical location, periosteal stripping. Was less than 10 centimeter, 10 to 20, or more than 20, or circumference also. More than 50% circumference if periosteal stripping is done over like almost complete limb length, then it will have more chances of pathological fracture. Mechanism of RT-induced fracture: radiation-induced vascular fibrosis, impairment of osteoblast cells, avascular necrosis, and bone atrophy. These all lead to fractures. Management: after fracture, there is management is very hard, and non-union chances of non-union are as high as 60%. So we should do prophylactic intramedullary nailing in patients with high risk of pathological fracture, which are more than 50% circumferential periosteal stripping over almost complete length of the bone. So median time to develop the pathological fracture is 4 years, according to the one study done by Godzeg et al. And fractures developing in the radiation field and were associated with minimal energy also. There is a nomogram to predict the associated fracture risk. So here see in females, the risk of fracture is more. As the age increases, the risk of fracture is more. In anterior compartment, if the tumor was there, the risk of fracture is more. Tumor size increases, the risk increases. With the radiation dose, the risk increases. With the periosteal stripping length, the risk increases. So based on that, we can assess that the patient is high risk or not for the RT associated fracture and can do prophylactic intramedullary nailing. So this is it. We will discuss brachytherapy and some new trials regarding the role of RT in sarcoma in the next slide, whenever I will present. Thank you for listening.
बहुत ही
सो गए क्या
डिफिकल्ट
सब?
टॉपिक था. सो नहीं गए. इसमें
सो
किसी को कुछ डाउट नहीं आ रहा है.
तो कंक्लूड कर दीजिए, आप कर दीजिए, क्या समझ आया या मैं ही करूं?
मेरे को तो इतना समझ में आया. प्री ऑफ आरटी शुड बी कंसीडर in patients which
Okay.
we are thinking ki low dose, because we are giving low dose everything is fine, but overall survival not there is not much difference in some papers are saying ki overall survival is different and it's significant also in pre-op RT. Otherwise wound complication double हो जा रहा है, तो wound care and all it will be is a trouble task. What in your
Acute wound
practice in
complication is
other institutes, what you people
acute.
practice regularly? Anybody's there?
सब सो गए लगते हैं.
कौन कौन है?
मोहन
We
का
prefer
क्या?
post-op party only in our institute.
Anyone prefers
Okay.
उनके इंस्टीट्यूट में प्री ऑप पार्टी?
साइज मैटर्स. अगर बड़ा साइज है, मार्जिन्स नहीं आएगा बोलो तो आरटी देते, अदरवाइज पोस्ट ऑप होती है ओनली. एंड इट आल्सो डिपेंड्स ऑन द
न्यूरोवास्कुलर बंडल के पास अगर होता है, आई थिंक फॉर सच काइंड ऑफ पेशेंट्स वेयर मार्जिन विल बी डिफिकल्ट, प्री ऑप आरटी कैन बी कंसीडर्ड. We have given
This entire talk was only for extremity sarcomas, not for retroperitoneal sarcomas, right?
Yeah. Extremity and like gluteal or say trunk.
And
Okay.
upper
It was for soft tissue as well.
upper
It
extremity
was also for
में
soft tissue only.
what I learned कि upper
क्योंकि ना
extremities
recently-
में complications are less. So for upper extremities, if we are thinking कि we can go for limb salvage surgery for after RT, then for upper limb we can consider more pre-op RT as compared to
प्री
lower.
ऑफ आरटी.
Yeah, still depends. Like it is for surgical, from surgical side, it is like hardly preferred. Pre-op RT hardly anyone prefers except the indication of limb salvage. If the disease is very much advanced and we have to attempt limb salvage, we have to give. Otherwise, I think no one is giving, as I discussed with sir also. So mostly they don't prefer for like for this radiation guys or like for discussion purpose.
ऐसा भी फॉर एग्जांपल इफ साइज इज लेस देन 5 सेंटीमीटर्स एंड इट इज हाई ग्रेड, फिर भी सर्जरी करते हैं ना. अकॉर्डिंग टू यू, इफ इट इज फॉर लेस देन 5 सेंटीमीटर हाई ग्रेड आरटी देना है.
Yes.
पोस्ट ऑफ.
For all high grade RT should be given.
हाँ. So size also matters, I think.
Size also matters, but like
For high grade side
we
doesn't
see-
matter na. For high grade side doesn't matter.
हाई ग्रेड साइज डजंट मैटर. बात तो सही है, मगर वेदर टू गिव वही है.
so practical is different than like
पोस्ट ऑफ आरटी.
practically we are seeing that it is not given that much. Even sir refused to give. Sir was telling that we hardly give, especially in I'm talking about bone tumors. So in osteosarcoma, sir is telling that he hardly likes to give. In Ewing's sometimes, unless the margin is close or positive like that.
नहीं, और एक
But
क्वेश्चन थी.
this is
ये तो
exactly-
टॉपिक. हाँ, आनंद
but
बोलो.
this thing now is exactly reverse with retroperitoneal sarcoma. Because now recently we operated one large retroperitoneal sarcoma. उसका ना HPA में focally margin positive था. So when we check NCCN guidelines ना, even with focally margin positive is nothing but R1 resection only.
One patient presented to us with liposarcoma, huge liposarcoma. ऐसे में encasement हो रहा है उसका. For this kind of
margin positive में that becomes R1, but in retroperitoneal sarcoma में ना R1 हो तो भी there is no indication for RT.
It is like a ball and everything is there. It is hard to give RT in abdomen.
Yeah. In a post-op setting, there is no indication also in NCCN guidelines.
Yeah.
Only with R2 resection में जाके, yeah.
आनंद, ये retroperitoneal sarcoma only for liposarcoma or any sarcoma? So
Any
post-op
retroperitoneal.
focal margin for there is no indication for post-op RT.
No. Even if it is R1 resection, there is no indication for RT. Only
Okay.
systemic chemo का है, but there are systemic chemo का there are few indications है. Only if it is fulfilling those criteria, systemic chemo का है. But there is no indication of RT, post-op RT in R1 resection of retroperitoneal sarcoma.
Retroperitoneal sarcoma. Okay.
Yeah, ये tumor mode में भी discussion हुआ था हमारा recently.
नाइस पॉइंट ना। हम लोग के पास मोस्टली इनऑपरेबल ही आते हैं एक्चुअली रेट्रोपेरिटोनियल ट्यूमर्स।
बाकी कुछ नए आर्टिकल भी है, वो नेक्स्ट टाइम अपन प्रेजेंट करते हैं। इसमें क्लास में थे नहीं तो मैंने
राकेश, एक्सट्रीमिटी सार्कोमास में अगर सपोज साइज इज मोर देन टू सिनेरियोस, साइज ग्रेटर देन 10 सेंटीमीटर, लेस देन 10 सेंटीमीटर और ग्रेटर देन 10 सेंटीमीटर है तो प्री-ऑप आरटी देंगे इफ इट इज लो ग्रेड, और इफ इट इज हाई ग्रेड तो प्री-ऑप देते हैं। लो ग्रेड मोर देन 10 सेंटीमीटर भी देंगे?
No, it all depends on the resection. Like we have to spare the neurovascular bundle or not. Like with size pre-op versus post-op, I think no one is giving pre-op RT. Post-op, everybody. Yeah.
What about fibromatosis?
So pre-op
Fibromatosis को you people are considering soft tissue or it is a separate entity?
They have removed, they have changed this fibromatosis. Earlier it was STS, now they have changed it to separate entity.
Is there
are
a
few
chapter
things
in
just small.
DeVita?
Yeah. This is given in AJCC also. There are few things they have removed from soft tissue sarcomas. Like they have removed cyst, they have removed desmoid, they have removed this fibromatosis also, I guess.
Because in our hospital
AJCC.
I am facing problem in managing fibromatosis. Back to back I got 3 or 4 patients, one of abdominal fibromatosis, one is of chest fibromatosis, one is abdominal fibromatosis, and one paravertebral fibromatosis. And after it's like there is a very early recurrence within a year of operation, within 1 month of an operation, and there is no approved drug also for fibromatosis in chemotherapy as such, and everybody is fighting in tumor board regarding management. That's why I asked, is you people know aware any chapter in DeVita